Welcome, everyone. I'm Jeff Bumpus, President of the American Board of Otolaryngology Head and Neck Surgery, and this is the 2026 Oral Exam Candidate Town Hall. And we welcome you guys here and are excited to see we have a great number of participants this evening. So what I'd like to do is introduce our panel that will be kind of conducting this webinar. I'm pleased to first introduce Tim Smith. Dr. Smith is the chair of our assessments committee and will moderate this panel. Dr. Galen Garrett is past president, immediate past president of the American Board of Otolaryngology Head and Neck Surgery. Dr. Ron Cooper-Smith is our president-elect for the American Board of Otolaryngology Head and Neck Surgery. And of course, Dr. Brian Newsenbaum is our executive director for the board. So without further ado, so we can really get into the meat of the matter, so to speak, I'm going to turn the program over to Dr. Smith at this point. Tim?
All right, great. Well, thank you for the kind introductions. Welcome, everybody. We're going to talk about case logs primarily this evening, but we'll start out with just a couple of slides to frame the conversation. And we like to go through some of this with each presentation so that we can help you all to understand what our philosophy is, what our mission is, and what it is we're trying to accomplish, why we've made such dramatic changes to this process. We want you all to fully understand that as well. Brian, do you want to share the slides?
Sure, very glad to, Tim.
And you can go ahead and advance through our introduction slide, and we'll get to our mission statement. We really like to review this in every meeting that we do. The American Board of Otolaryngology Head and Neck Surgery serves the public with emphasis there. We serve the public by assuring that diplomates meet our standards of training, knowledge, and professionalism through both initial and continuing certification. And of course, this evening we're talking about initial certification. Next slide. And a framework around, why have we made changes to the oral examination process? And this goes back to Miller's pyramid, which was described, decades ago, and is a framework for the assessment of clinical competence. And, historically, we have stuck in the lower levels here, the cognitive knowledge levels that the candidate knows and knows how. And now we're branching up to the performance levels where the candidate can show that they know how to do something, or that they are actually doing something in their practice, and we're assessing that. So in the lower two levels of the pyramid, there are knowledge tests. Such as written examinations. Our current written examination is a good example of that. And applied knowledge tests, such as our prior oral examination test using standardized protocols that were presented to all candidates, were the way that we measured these things. And now we're really moving along the pipeline here to really the top tier, which is our current evaluation of your performance in your real world practice during the first, several months of your real world practice. So that's the framework through which we've thought about this. Now, keep in mind that, next slide, please, that the written exam, it will remain the foundational knowledge assessment. It looks at the breadth and the depth of the entire specialty of otolaryngology head and neck surgery. And the timing of that assessment is unchanged. Now, with the the oral examination, this is going to be an assessment of the skills that are required to safely practice our field. And so the content in this case is going to include only the cases that come from your practice, both surgical cases and non-surgical cases from your own practice. You can initiate the application during the first year of independent practice, and we don't require a variety of cases or a certain complexity of cases. We want you to practice the way you practice, and we will assess the cases based on that practice. So with that introduction, I'll hand off to Brian Nussenbaum to get to the real focus of our conversation this evening, which is about the case logs. Brian.
Yeah, thanks, Tim. And in this figure, you could see going from the top to the bottom. At the top is what the candidates on this webinar have already gone through, is meeting the eligibility requirements and having your application approved by the board to move forward with the oral exam process. And you could see at the very bottom is the oral exam that you'll be taking and what happens in between. In terms of the credentialing process for the oral exam, it's not only meeting the eligibility requirements and having your application approved by the board, but also the case collection and handing in a case log, as we're going to be talking about tonight, and then also the peer review process. And all of this is part of the credentialing for moving forward with the oral exam. The case collection process will be starting next week on January 15th. The peer review process will be starting August 4th, and that's something that there'll be further communications with down the road in terms of what that will entail. But we're really going to be focusing on the case collection tonight, that once again, the process starts for everybody, for all the candidates for the 26th exam next week. One of the questions that we do get asked is, what is the purpose of the case logs? And I do want to, before going into the details, I do want to say that this is a frequent way that certifying boards in surgical fields credential candidates for their oral exam. Neurosurgery, plastic surgery, urology, orthopedic surgery, obstetrics and gynecology are 5 examples of peer boards in the American Board of Medical Specialties, the ABMS community, that already for many years have required, as a credentialing process, the candidates have a period of time of collecting case logs prior to their oral certifying exam. The purpose is twofold. Number one, as I've said, credentialing for the exam, ensuring that the candidate meets the minimum required volume of cases, and also by the board reviewing your cases during that 9-month period of time, that the board believes from the information you've provided that you are providing safe and effective care in your autonomous clinical practice after completion of all training, including ACGME or non-ACGME accredited fellowship training. So that's one of the reasons why, as a candidate, you're not able to apply for the exam until after you're completed with all training, and none of the cases submitted for the exam can happen during your training, including fellowship training. This needs to be when you're outside of the training environment in independent autonomous practice and making those independent decisions on your patients. Now, secondly, in addition to credentialing for the exam, it's for the board to be able to look through your cases and select the cases for your actual oral exam. As we'll talk about, the cases on your oral exam are not going to be randomly chosen during the exam from every case in your case log. You'll know the exact cases that we're going to be testing you on your exam day. But we want to make sure that the cases that we select in advance of your exam are cases that are reflective of your overall practice during that 9-month period of time. So that these are the 2 main purposes of the case logs. Now, in terms of the case collection period, the duration is 9 months long. All candidates have the same start date and the same end date. This is a question we've been asked, is that when do I start, or when can I start? or can I change the dates? The answer is no. You cannot change the dates. It's standard for all candidates. You start January 15th, you end October 13th. It's 9 months long for all candidates. Now, we do recognize that there are some candidates that are going to be taking parental, caregiver, or medical leave during this 9-month period of time. And the board will allow, if this is allowable time away from your practice, for up to 3 months during the 9-month case collection period, the board will allow for that if that's been approved by your workplace. While it is a 9-month case collection period, it could be as short as 6 months for the candidates that are on parental, caregiver, or medical leave approved by your workplace during that period of time. I do want to mention, though, that the minimum case log requirements still need to be met, even if you have a shorter period of time that's approved by the board, and that documentation from your workplace needs to be submitted to the board prior to the leave starting, and we need to approve it prior to the leave starting. But I do want to emphasize here, it's not a 6-month case log, it's a 9-month case log. It's just we are going to we know that there will be exceptions granted for shorter amounts of time for individuals who are out of their work environment, approved by their work environment for parental, caregiver, medical leave during that 9 months. Now, in terms of the operative cases for your case log, the operative, every operative case you do during that 9-month period of time needs to be put in the case log. I will emphasize all surgical cases. We had some questions come in advance. Do I put in my operative cases if I have temporary privileges at a hospital? The answer is yes. Do I need to put in all my cosmetic cases? The answer is yes. If a cosmetic case has a CPT code, that's the code you use. If the cosmetic case does not have an established CPT code, if you read the case log guidelines, there are instructions specifically of how to input those cosmetic cases into your case log. Another question, do I need to put in every set of ear tubes that I put in? The answer is yes. Do I need to put in every tonsil? The answer is yes. As I will review, we have created a process where candidates can create templates for high volume procedures or high volume diagnoses to make it very simple and easy for you to enter a case. So using the templates, which have been heavily utilized by the group that came before you, will make it easier to efficiently and quickly put in high volume cases like tubes and tonsils. So I will emphasize this, all consecutive surgical cases during that 9 months needs to be input into your case log. The minimum number of cases for us to review it at the end of 9 months is 40 cases. That does not mean when you get to 40 or 41, you stop putting cases in. You put in all the cases during that 9-month period of time. Now, it says over here, you could see the bullet points, hospitals and ambulatory surgical centers submit all cases. We feel this is pretty obvious. What might not be obvious to the candidates is that therapeutic procedures that you do in the office, like balloon sinuplasty, like injection laryngoplasty, like wide local excisions of skin lesions, like excision of keloids, those types of therapeutic procedures that you do in the office do need to still be put into your case log as an operative case. The board considers the case as an operative case, even if it's done in the office, if it is a therapeutic procedure. And that's what's really meant by an operative CPT code. Now, what are some examples of non-operative CPT codes? And the way to think about this is if the procedure you're doing is a therapeutic procedure, in all likelihood, It's not going to be on the list of non-operative CPT codes that you do not need to put into your operative log. Some examples of non-operative CPT codes are diagnostic endoscopies, like fiber optic laryngoscopies, biopsies, including fine needle aspirations with or without ultrasound, tracheostomy tube changes, sleep testing, allergy testing and immunotherapy, canalith repositioning, facial fillers, any Botox, and chemical peels. These are examples of what the board would consider non-therapeutic, non-operative CPT codes. And most of these are going to be diagnostic types of procedures rather than therapeutic procedures. But once again, if it's a therapeutic procedure in the office, and in your case log guidelines on the portal, there's a list of all, there's a list of all the non-operative CPT codes. But the way to generally think about it is if it's a therapeutic procedure, it's likely going to be an operative CPT code. Now, we do want to mention very specifically about cerumen and binocular microscopy. These are never included. These are not in the system. They're never included unless they're performed in the operating room. So cerumen and binocular microscopy are never included unless they're performed in the operating room. And as I mentioned, a comprehensive list of the non-operative CPT codes that do not need to be put in as operative cases is available on the portal. Now, a few reminders that each case is a unique patient, no matter how many procedures you do on that patient, whether they're staged or reoperative. So for instance, if you do a hemithyroidectomy for an indeterminate nodule and it turns out to be malignant, and 2 weeks later you have to take that patient back to the operating room for a completion thyroidectomy, that counts by the board as a single case. The number of cases is the number of unique patients that are in your case log. The way you would handle that is that you would enter a second operative case in your operative case log, but use the same linking medical record number as the index case, so that way we could link the two cases together at the end of the case log process. Secondly, no unbundling is allowed. So a case is actually all portions of that operative session. So for instance, if you do a total laryngectomy and bilateral neck dissections, that is not 3 cases and three operative entries. That's a single operative case and a single operative entry. Co-surgeon cases, you should be submitting if, as a candidate, you are a billing surgeon. So in other words, if this is being billed as a co-surgery case, then you should be submitting it as if you're a billing surgeon. Now, a question was asked in advance, should I submit a case if I'm an assistant surgeon? Assistant surgeon cases are not modified with a 62 modifier. They're modified with an 80 or an 82 modifier. If you are billed as an assistant surgeon with an 80 or an 82 modifier, that is not something that you would submit as an assistant surgeon. As a co-surgeon, where you're a billing surgeon, as a co-surgeon, you would be submitting those cases, but not as an assistant surgeon. It really boils down to how it's billed in terms of what the modifier is. Now, in addition to the operative cases, you are required to submit 40 non-operatively managed patients from your practice during the 9-month period of time. The board certainly recognizes that it's not practical or realistic to ask you to submit every non-operative patient for a 9-month period of time. So we're certainly not asking you to do that. But we do want to get a sampling and a biopsy of what your practice looks like of the patients that you're not operating on. And so what we ask is that you, as the candidate, declare a start date for entering the 40 consecutive non-operative cases. And that start date needs to be before April 10th, which is 3 months after the case log portal opens. When you log onto your case log for the first time, when you click on the non-operative icon, you'll see at the top where it's pretty straightforward. There'll be a field for you to click for you to enter the date that you will start the non-operative case collection. And this is where we really, once again, we want to get a sampling and a biopsy of that 9-month period of time of what a period of your practice looks like of patients you're not operatively managing, that you're not operating on. And so so from the time that you declare as your start date, we want you to enter 40 consecutive patients you see where your initial management plan is a non-operative management plan and does not involve an entry into the operative case log. This includes all clinical sites, not just one of your clinical sites, but all clinical sites, inpatient consults you see during this period of 40, and emergency room consults that you see during this 40. So, so this isn't one specific site, it's all your sites, it's 40 consecutive patients you see in the outpatient clinic, as an inpatient consult, or as an emergency room consult, that your initial plan is a non-operative management plan. Now, it's quite possible that you see the patient as a new patient or a consult, and you don't know if the plan should be operative or non-operative. In that case, wait to see how it plays out to see if they get entered in your operative case log or you enter them as a non-operative case. You know, for instance, there might be an imaging study you need to order, or another test you need to get, or you might need to see how they do with initial trial of antibiotics. So see, you know, there are going to be situations where it's pretty obvious and clear the plan is operative or non-operative. There are going to be situations where it's unclear during this period of time. And that's where you just want to see how things play out and then determine if they go in your operative log, if you operate on them, or if they go on the non-operative case log. Tim, before we move on to screenshots of what the case log portal looks like, this might be a good time to see if there's questions for us to verbally answer.
Yeah, thank you, Brian. We've been answering and are answering as we speak, several that are coming up in here. I'll point out that I was incorrect with one of my answers. I've since corrected it on the difference between an assisting surgeon and a co-surgeon and the codes related to that. So that's been corrected. I don't think there's anything in here that we need to call out at this time, Brian. So why don't you just keep going and we'll keep answering them in the chat.
Hey, Tim,
Great.
Brian, there.
can I just, oh, I was just gonna.
Go ahead, Galen. You're fine.
I think a lot of the questions that are being asked are covered later in the presentation.
Okay.
And so we'll try to answer them as much as we can, but I think also if you stay tuned, you'll get some of those answers.
Brian, one that I just said we would answer live. There was a question about non-operative managed patients. How about cosmetic practices? Usually patients are candidates by the time they reach our consult. I would say that we still want the non-operative cases. For example, you might evaluate a patient who you do not think is a good candidate for a cosmetic procedure, say perhaps a rhinoplasty or aging face surgery, and you have compelling reasons why that would not be a good option for this patient. That would be a type of non-operative case that we would like to have available and would like to be able to discuss with you. So, you know, including this is important material, because I will presume that most of us, really, regardless of subspecialty, are going to have patients we do operate on and those that we recommend that they do not have operative care.
Yeah, and Jeff, to that point, I know with the first group that's come through, a lot of the individuals that have a focused, you know, referral type of facial plastic practice, a lot of their non-operative cases have been, both neurotoxin patients and facial fillers that are considered non-operative CPT codes by us. So those would be considered non-operative cases.
Great. Thanks, Brian.
Should we move on? Okay. So there's going to be a lot of screenshots here, and these are screenshots that are taken directly from the case log portal that you'll have access to next week. There was a question of, could I use a case log portal from my own practice? The answer is no. All candidates have to use this case log. This is the only case log to use. And another comment I'd say is that there were some candidates that, with the first group, that we noticed were not entering cases in a timely manner. And when we reached out to them to make sure things were going okay, they said, oh yeah, things are great. I'm just keeping my own Excel spreadsheet of all the fields in the case log portal, and then I'm just going to enter them all in a batch later on. And I really think if you want to do that, you can, but it's really just doing double the amount of work. It's just going to be easiest to just put things in the case log the first time rather than your own spreadsheet and then transfer them later on. So in the upper right-hand corner of our public website, there's the physician login. After you log in, starting next week, there'll be a tile that says go to case log system. And when you click on that, there's a multi-factor authentication step here. And you'll see here where it's circled in purple, it's --9118. That's my cell phone number. This is one of the reasons it's critically important that we have your correct cell phone number on file. Because whatever your cell phone number is on file, that's what we've sent to our technology vendor that is going to be used for multi-factor authentication for you to get access to the case log portal. So if you're, I would advise you, if you're unsure if we have your correct information based on what you provided during the application process, log on to your portal and make sure that your cell phone listed with us is your correct cell phone. If it's not, please actually get in touch with us as soon as possible so we can have that change before next week. After the multi-factor authentication step, this is what you'll see on your screen. You'll see at the top here, operative cases. You can see that I entered 8 operative cases and 1 non-operative case. So the tallies are at the top. And you can see underneath here, this is where you'll see if or when you create templates, I should say when you create templates, most of the candidates did during the last group, this is where you'll see your templates. And let's look at the operative cases first here. And so when you click the icon for operative cases, you'll see a listing of everything you've put in so far. And you could see what's on the dashboard. And for each of the rows, each of the columns, if you click on the title of the column, it'll sort it in an order. So like, for instance, if I clicked on date of surgery, it'll sort it in the dates that I did those surgeries. And so you can see the details on the dashboard here. Now, once you enter a case, you can always re-enter the case and edit the information. So if you put in some of the information, but not all the information, you could come back whenever you want to, and you could complete it. Or if you need to update information about a patient with follow-up, you can certainly just click edit and add the information as needed. I do want to point out there's a delete also. And the reason I'm pointing out there's a delete is that once you get access to the portal, you may want to just play around with the system and try adding and removing some case, just playing around with the system, you could do that and delete what you do. So, but keep in mind that you can delete if you want to. Now, once if you click, say, edit and go into a patient entry, and this is, you could see an example. the patient initials, patient ID, whatever you put in as the patient ID, the patient age, and their instructions there in terms of if they're less than 1 year old, how to deal with that. You would enter the location where you took care of the patient, and you could add as many inpatient, outpatient locations as you need to in terms of facilities where you take care of patients. The brief diagnosis, which you would type in, and then here where you'd put in the ICD-10 codes. We would really advise that you know the ICD-10 codes, the CPT codes for the outpatient, the E&M codes. It's going to be a lot easier for you to know the codes before you try to enter them here. You certainly can use this. If you click Enter New Code, you're going to get this field here where you could search by the ICD code, or you could search by a keyword. But keep in mind, this is not designed or made as a CPT or an ICD code finder. In terms of myself and putting in a few of these sample cases, I found it much easier just on the Google search bar to find the information rather than remembering the exact keyword to use for an ICD code, which might not be so intuitive. So we would recommend that you have your codes in advance if it's possible, but you certainly can use the system if you want to try to find them. Then there's this classification of disease where you can pick up to 2. Certainly, if there's only 1, please only put 1, but you could put up to 2. Now, you can see over here, pediatrics automatically checked off. If the patient age is under 18, pediatrics going to be automatically checked, and you don't need to click a second one in those cases. If you want to, you can, but you don't need to. And if the patient age is 18 or more, you're actually not allowed to click pediatrics. So the pediatric button on the classification of disease is going to be on or off when you get there, just depending on what age you put in for the patient. Then here you'd enter the date of the surgery. If you're entering the case the day that you do the surgery, that's going to be the default date. And then if it was elective, emergent, or urgent, and then you hear where you put the brief description of the surgery and follow-up. There are no modifiers that we have in the CPT coding. So if this is a bilateral procedure, in the description of the procedure is where you'd want to note that it was bilateral. And follow-up is very important. We do expect that there is follow-up on the patients you operate on in terms of what the outcome of the operation was. Was it a successful operation or not? There's a maximum of up to 1,000 characters in this space for you to put follow-up. And we do expect follow-up that's pertinent and relevant to the operative care you provide to that patient up to the end of the 9-month period of time to be included in the case logs. So all complications and follow-up related to the care, the operative care you provided to these patients needs to be provided through whatever happens to the patients up to the end of the case logs closing, which is October 12th at 11:59 p.m. Now, if there's a complication or follow-up that leads to another operation being necessary on that patient, you need to re-enter that as a new operative case using the same patient ID number that you used for that original index case. Once again, complications and follow-up that requires another operation. A second operation's not an amendment or addendum or an edit to a previous entry. It's a new entry. Every operation you do is an independent entry in the system. It's just if it's on a patient you've already operated on, it would be you'd use the same patient ID number used for the first one for any subsequent ones. Now, if the complication of follow-up does not involve an operative session, this is where you would edit the original case entry And in that section, brief description of surgery and follow-up, the free text box is where you type in the necessary details. In terms of the next item on the screen is the CPT codes. And once again, this is an area where if you click enter code, you can search by keyword, you can search by CPT code, but it's probably easier to use a coding search engine outside of the case log to try to find these rather than the case log. Once again, if you want to, you can try doing it. It just it might be easier to find these codes otherwise. The next thing is whether there are complications, and there's a field, were there any complications, yes or no? If the answer is no, then there's not much there. But if the answer is yes, then you'll see here whether there's an adverse event complication. You can see at the top related to readmission, reoperation, or mortality, related to a surgical complication, an anesthesia complication, or a medical complication. And for each one of these, there's an accordion. So we didn't want to make this screen as something that was like an eternal scroll, because there's some of these categories like medical complications, there's lots of different things to potentially look at and choose from. So if you click yes, then this is where it accordions out. So like on the first one where it's readmission, reoperation, mortality, if this was no, you would not see the additional details of the 3 boxes to potentially check. But if there was a surgical anesthesia or medical complication, you click yes, and then you would put in the details there. And then there's a free text box at the bottom to put additional information as needed. And if there is a complication, we do require that you give a Clavien-Dindo grade to the highest level of complication. This is a grading system for surgical complications that has been used since the 1990s. It's been validated. There's hundreds of papers in the literature about this grading system. But you are required to give a Clavien-Dindo grade to the highest level of any complication on your patients. Now, in terms of the non-operative case logs, these are there are similar fields, but there's not all the fields are there because you didn't operate on these patients. So, so this is an example of a non-operative case entry, a 25-year-old seen in the outpatient office. That you can see here, the brief description I put in here is a soccer coach who presents with worsening hoarseness for the past 3 months. You can see the ICD code I put in was for dysphonia. You could see the office, the location was XXXX office, so a fictitious office that I put in there. And then there's a classification of the disease. For this one, it would be laryngology, the date that you provided the care, and that the brief description of the care. And once again, this is, you could see here, what I put in here is an example. Patient evaluation revealed bilateral vocal fold nodules. Speech therapy initiated, follow-up will be in 3 months. And if that 3-month follow-up is during the case collection period of that 9 months, in 3 months, when I see that patient back for follow-up, I'd go back into this case log and describe how the patient was doing 3 months later. So there's appropriate follow-up documented on the care that I provided to that patient. For the, not for the operative cases, but the non-operative cases, there is the E&M code. And then if there is a CPT code on the patient. Now, this is a non-operative CPT code. This is a non-operative patient. I didn't operate on this patient. I did a flexible fiber optic laryngoscopy on the patient, and I put in that CPT code as such. It was coded on the patient, but it's a non-operative CPT code. Once again, it's a diagnostic procedure. And the complication field is much more narrow on the non-operative cases. Here, it's just, did an adverse event happen, yes or no? And if so, a free text field to type in the details. I did mention templates earlier. Templates are really important. There are going to be high volume procedures or high volume diagnoses that you have in your practice that it's going to be really helpful to create templates. Creating templates is super easy, super quick, and it makes it very efficient for those high volume procedures in particular to put those in, like tubes and tonsils. You can see over here is an example I created, and it took me, I think, maybe 5 minutes or less to create each of these templates. I created a template for adult tonsillectomy. I created a template for bilateral laryngotomy and tube placement, and I created one for hoarseness as a diagnosis. So once again, the templates can be made directed to a diagnosis or directed to a procedure. Tim, before we move on, I think it's a good time to take a brief break to see if there are any questions to answer.
Yeah, we've done a good job, I think, answering all of the questions as they're coming up in the chat, Brian. So why don't you keep going, and we'll keep working through the answers.
Okay. So October 13th, when the case log portal closes, is not the date you need to have everything finalized. That's the date where we end, that you as a candidate end collection of data for your case logs on that date. But we give you until December 2nd, so we're giving you about 6 to 7 weeks more to review over all your entries during that time, make sure all the data is accurate and everything is complete. So once the case logs, once again, I'll repeat that, when the 9-month period is completed, you have an additional 6 to 7 weeks to finalize all the information that's in your case logs. Make sure it's accurate and complete. And that deadline will be December 2nd at 11:59 p.m. At that point, you do have an additional 2 weeks that once you finalize your case logs, for each of your clinical sites, there will be a downloadable summary of all your cases that you reported from that clinical site. And you will need to get verification signatures on cover pages for each of those clinical sites. And there'll be further instructions given before this all happens about what signatures you need to get. But this is the validation and verification process from the board that you are accurately reporting all the procedures you did at each of the sites. So once again, you're getting extra time to finalize and then time to get leadership signatures, sign off, verifications that everything is actually complete of what's on your case lists and that you didn't leave anything out. Now, you don't necessarily have 2 weeks to get those verifications unless you wait till December 2nd to finalize things, and then you have 2 weeks to get the signatures. You really have a total of 2 months from the date the case logs close to December 15th to finalize your list and get all the signatures that are necessary. So some reminders and advice. The operative cases are everything, not a minimum of, not only 40, a minimum of 40 cases, but everything you've done during that 9 months that's operative in the hospital, in an outpatient ambulatory surgical center, or in your clinic. The non-operative cases are only 40 cases. We don't want more than 40 cases. They have to be consecutive, and they're from the date that you declare and select within the first 3 months of the case log opening up, that you collect those 40 consecutive patients that your initial treatment plan was a non-operative treatment plan. All complications and follow-up related to the care you provide is required to be input into the case log. once again, related to the care you provide. If you do an operation, we want to see in your case log that you're following up with your patients and what their outcomes are. That's part of the case log process. There needs to be follow-up on your patients. As candidates, you are responsible for all the information in your case log. There's a multi-factor authentication process to enter in the case logs, but we really want you as the candidate to be entering this information. Keep in mind that if you delegate this to somebody else to be entering the cases for you or entering the information for you, you are the one that is responsible for the information, not somebody else. And we would really strongly encourage you to use the templates for common procedures or diagnoses. Lastly, don't fall behind in the entries. So when you were a resident and you were doing the case logs for ACGME, you likely had a program director or a chair who was constantly watching and trying to incentivize you to keep up with your case logs. Here, you're not going to have a program director who is incentivizing or motivating you to stay up, and to keep up. But really, if the best thing to do is to enter real time, and to try to get a cadence that works for you, but please don't fall behind in getting your case entries entered. The worst thing to do is wait till the very end and then try to enter everything at once, because you'll likely be poorly successful at doing that. There are a lot of materials on the website, and including FAQs. A lot of people don't read FAQs. Actually, there's a lot of good information in FAQs. So if you log into your physician portal at the bottom, go to oral exam, go to the oral exam cohort year. You are the 26 cohort. You're not the 25 cohort. You are the 26 cohort. So make sure you click the 26 cohort. Behind that, you'll see a whole bunch of tiles. There's not information behind every tile, but there is information behind most of the tiles. I do want to point out a few things. Number one, at the top, you see the 26 oral exam timeline. I would encourage you to look at that timeline and download that timeline and be aware of all those dates. If you click on the case collection and case log portal, there's a lot of information behind that tile. And then FAQs, there's a lot of information behind that tile. If you click on the timeline, this is the timeline that you'll see. Once again, a lot of good information. If you click on the case log and case log portal tile, you'll see here a lot of information, including the guidelines that you can see the red box around. Strongly encourage you to read the guidelines and be familiar with the guidelines. There are also a few instructional videos on how to add a case, how to create a template, and how to use and apply a template. Now, these videos were made for the previous cohort. There are some differences in the case log portal itself in terms of the names of some of the fields. But for the most part, you'll get the gist of in the very quick, brief videos that show you how easy it is to either enter a case, create a template, or apply a template to a case. And then the FAQs that you can see are divided up into these 4 sections, and each one accordions down with information. Tim, maybe before we move on to some details about the exam, are there any further questions?
Yeah, we had an interesting question. You know, I know we've crossed this bridge before. I just wanted to make sure I got the answer right on this. So our colleague works at a county hospital system that does the billing for the physicians.
Yeah.
And so what the county actually bills is not entirely transparent or clear. This happens in different systems, you know. So what codes, should they just use the codes that they think reflect what they did? Or I'm forgetting, is there some process whereby the board gets the actual sheets that are submitted to insurance?
Yeah, I think the best way to handle that, Tim, is for the candidate to enter the codes what they feel is accurately reflects what they did. If the case is selected for the exam, for all the cases that is selected for the exams, the billing sheets are going to be included in the materials that go forward for the exam for the cases that are selected. And if there is a discrepancy, there might need to be a discussion about why there's a discrepancy during the exam. It doesn't mean it'd be held against you. It might generate a discussion why there's a difference. But there's, I think if somebody is in a situation like that where they're not in control and they're unclear, I think the best thing to do is enter what's most accurately reflects and represents what's in their operative report.
Great. And just the person who asked the question, know that you're not alone in that. There are other candidates who are practicing in scenarios. We've heard this before. So
yeah. Now, one of the questions we're asked is that why is there so much time between ending case collection and the exam? And that's because there's a lot of candidates, and the board needs to look through all the case log data and the peer review evaluation data that we get. We then need to go through the case selection process. We then need to go back to the candidates that are approved to move forward with the exam with your selected cases for the exam, and you need time to upload the materials for the exam. And then the examiners need time to review over the materials on the candidates' cases that they're assigned, and then the exam needs to happen. So there's a lot in this red box that needs to happen between ending case logs and the exam itself. Now, in terms of the exam itself, in terms of the details, there are as I mentioned at the beginning, the board is not going to pick during your exam. We're not going to look at your case log and pick 10 cases at random during your exam from a few hundred cases in your case log. We're not going to do that. You'll know in advance exactly what 10 cases are going to be on your exam, and it's going to be a mixture of operative and non-operative cases. Once again, we want to make sure that the 10 cases chosen for your test are 10 cases that reflect the entirety of your practice. So they'll be selected in advance and known to you as the candidate. There'll be 2 exam sessions with 5 cases you're tested on per session. Each session will be 50 minutes long, so 10 minutes per case. And this is very typical for the boards that do exams like this, that they allow for approximately 10 minutes per case. And there'll be 2 examiners in each of your rooms. So there'll be a total of 2 rooms, 4 examiners, 10 cases, 5 cases per room. The exam will not be a hybrid exam. It won't be a virtual exam. It will be an in-person exam. The only option for the exam will be in person. It will be at the assessment center of the American Board of Obstetrics and Gynecology, which is in Dallas, Texas. ABOG has built an incredible, brand new, very professional testing site facility that is really designed for giving oral exams. And it's really a fantastic place. We're really excited to be able to have access to their center to administer the exam there. The exam is scheduled September 24th to 27th of 2026. Now, there is a separate exam fee. One of the questions in advance is that, is there any additional fees beyond the $800 fee that I've already paid? There is. The $800 that you paid as a candidate is for the application and credentialing process, for the whole case log process, the peer review process, the process that of submitting all the materials for the exam, and also the process of selecting the cases for your oral exam. There's a lot that goes into that $800, but the actual administration of the exam is a separate fee, and that's $2,700. that will be a few months before your exam. When you find out the 10 cases, around that time is when we'll ask for collection of that fee. For any follow-up questions, you could email the board office at oralexam@abohns.org. As candidates, you are assigned to one of the board staff as your liaison or oral exam concierge. If your last name starts with A through L, Rosa Leneva is your oral exam concierge. If your last name starts with M through Z, your oral exam concierge is Nikki Leday. You can see their direct email addresses here. If you'd like to schedule a meeting to talk to me about any specific things, you could reach out to Marissa Zarate at that email address and ask to schedule a meeting to talk to me directly. With that, I think we have some of the submitted questions we want to answer, Tim, but wanted to thank everybody for their time this evening.
Yeah, thank you, Brian, for going through that. We had a number of questions that were submitted in advance, and we've tried to collate them a bit and group them a little bit. And so let's go through some of those. Do you have those on a slide, Brian, or do you?
I do.
Yeah, here we go. I'll pick on Ron first. Ron, do you feel prepared?
I'm prepared. We've been answering questions pretty solid here for an hour, so
Okay.
I'm ready.
Okay. So do cases done prior to the portal opening count?
No, they do not.
No, they don't. We don't put anything in there prior to the portal opening. And there were a couple scenarios that came up in the questions that you can read about. What if I perform an operative case for a complication related to a case that was done before the case collection period started?
Yeah, that would count as a new.
That would count because it's a case and it's during the collection period, right? Okay, next question. Do I need to submit the case if the surgery was scheduled by an APP?
Yes. I mean, I think the best way to think about a lot of these questions are if your name is on the bill, you need to submit the case.
Yeah. So. Very good. Do I need to submit the case if done by residents without myself being present?
Yes. If your name is on the bill, you need to submit the case.
Do I need to submit the case if done at the VA while staffing residents?
Yes.
Okay. And then do I need to submit all epistaxis cases if a procedure was billed?
Yes. I think as Dr. Nissenbaum said, if it's a diagnostic procedure, just in a general sense, then it's not a case. If it's an intervention, then it is a case. And there is on the website and in the presentation a list, and in the portal, a list of cases that are excluded, or codes that are excluded.
Okay, great. And I think we have a couple more questions about the operative cases. The first is, it's on the next slide, Brian. The first is, should I submit the case if the operative procedure was related to a complication from coverage of another's practice, such as a post-tonsillectomy bleed?
Yes. Any case that you participate in that you bill for should go into the log. Good.
And then the last question about the operative cases are, do locum tenens cases count?
This one has a nuanced answer, right? If you are spending most of your time, it's a long assignment, then yes. But if it's a short assignment, Brian, you might have to correct me here, then it's no. So it's generally no.
Yeah. Generally, the problem with locum tenens cases is that you lose access to the record and whatnot at some point, so you can't really provide follow-up on these. So if you were only doing short-term locums work during the case collection period, you really wouldn't be eligible for that case collection period. You would have to wait until your practice was more established.
Yeah.
Okay, let's move to some questions about non-operative cases, and I'll go to Galen here. Galen, what do I do if a patient was entered as a non-operative case, but then later needed to have an operative procedure during the follow-up period? This came up a couple of times in the chat too.
Yeah, thanks, Tim. And I think we did answer it there, but just to review, So if it's entered as a non-operative case, then it remains a non-operative case for those 40 consecutive cases. But if you do later decide in follow-up that this person needs an operative procedure, then you will now enter it as a separate operative procedure, but still using the same, patient ID number. And so the system will kind of match those up, but it might not be a bad idea to go and put a little note into your original, the non-op, and just put, hey, we later did a procedure, so just as a notification.
Okay, very good. Next question is, should I enter post-op or follow-up patients while covering for another's practice?
Yeah, if it's just routine follow-up, no, you shouldn't need to enter that. And only if that person for some reason needs to have a procedure that you are then going to bill for. But otherwise, no, that you would not be entering that information.
Okay. Should I enter patients that are checkoffs for APP's care?
So again, I think in this one, if you were just signing off on a patient that you are not directly involved in their care and are not billing for them, then no, you would not enter that patient.
Okay. Should I enter patients when I staffed the case for on-call residents but never personally saw the patient?
Yeah, I think this is kind of a similar scenario to the APP. If you just reviewed the case, just as like a phone call that said, yes, I was on call while this resident saw a patient, and you are not billing for that patient, then no, you would not enter them. However, if you do bill for that patient and it's part of your 40 non-op, 40 consecutive, then you would enter that case. If it's someone that you did not operate on, but dropped a bill and it was not outside of your 40 cases in a row for non-op, then you would not need to include it, if that makes sense.
That does. Okay, if I see a new patient, but refer them to a different otolaryngologist to perform their surgery, do I still log that as a non-operative case since I didn't perform the surgery?
Yeah, I mean, I think this will be a great example for a non-operative management on your part. So you would include it if it falls within that 40 consecutive non-operative period.
All right, very good. And I think we have one more slide of just some additional submitted questions here. I'll go with Brian for the first one. Jeff, you're on deck, so you better get yourself ready there,
Ready.
mister. Okay. How much detail on follow-up given the character limits? What character limits are there, Brian? And how much detail do we want?
Yeah, so there's up to 1,000 characters. So there's a fair amount of room, but we certainly don't want essays written. We're really looking for, for the operative cases, what was the outcome of the operation you performed? Was it successful or not? And what happened to the patient? And that's what we're not looking for a long essay. We're just looking for information to make sure you're following up with your patients. And I think the important thing about that, Tim, I think one of those questions was that about tonsillectomy. Could I, if my routine is a telephone visit, is that okay? That's fine. Then the follow-up description might be that a telephone call 3 weeks later confirmed they were doing well and no further follow-up was needed. It could be something as simple and concise as that. It could be something that is much more complicated if the patient did not do well. But we're just really looking for the information that, number one, that the validation and verification that you are following up with the operative care that you provided, and were the outcomes generally successful or not successful. And so that's be judicious about the information you provide and put enough that it's informative.
Okay, great. Let's see, Jeff.
Yes.
Can I add or remove clinical sites during the case collection period?
Well, the next couple of questions we'll address, Tim, kind of deal with changes in practice circumstances, and certainly adding a new practice site, particularly if it's one that you're going to be seeing patients at, is fine. I would say it's much more nuanced if you want to remove a site. So if you are contemplating removing a site, that's something that would require communication with the board. And you need to make sure that we have a clarity of understanding. Those circumstances, for example, could be varied. You know, it could be your entire practice is no longer practicing at that site, or it could be an individual set of circumstances that would cause you to not be at that site anymore. So, because there are nuances with it, it requires some discussion and determinations with the board.
Yeah, and so related to that, what happens if their employment changes during the case collection period?
I think that's very important. And again, this is a place where the board is there for you, and we want to be there to interact with you. So as soon as an event like that occurs, or you even anticipate an event like that, communicate with the board early, because that could change the circumstances. It could change availability to records at a former practice. It will also expand peer review and have some implications for the peer review process. So that's an important change, and it's one that could occur for a myriad of reasons. And therefore, it just requires more understanding on the part of the board. So we make good decisions and we help you navigate that in the best way possible. Brian, I don't know if you would have an additional comment on that.
Yeah, thanks, Jeff. And this is actually really, really important question. And if, as an individual, if during or after the case collection has ended, if any time between, I actually, why don't I rephrase this by saying, if any time between now and the exam on September 24th, that your employment is going to change, or employer will be changing, please reach out to us proactively early through your oral exam concierge, and let's have a conversation and let us know what's going on. It's very difficult if during or after the case collection to change employment, simply because when you change employment, in all likelihood, you will lose access to all the electronic medical records on that individual. And the board will not be able to select then any of the cases for your exam from your prior employment. And that creates a real major set of difficulties and problems. So if you are looking to change employment anytime between now, or at any time between now and September 24th of 2026, please reach out and let's have an early discussion conversation.
Okay, great. And then the last question we had here is, do I need to inform the board if I take time away from work, like going on an extended vacation? We already covered leave and the various forms of leave, Brian. What about if someone's taking time away, vacations, this kind of thing?
Yeah, thanks, Tim. And this is described in the case law guidelines that as a candidate, if you are going to be away from your clinical practice for 3 consecutive weeks or more, we ask that you alert us, let us know, and alert us through your oral exam concierge, and just with simple email to let us know why. And with the first group, the few people that have done that, it's just been extended vacations that they've been on. But really, the reason we'd like that is that when you hand in your case log, if we see periods of inactivity, of no, cases being done, we're going to wonder what's going on and why you're not doing cases, or, so like so if you're going to be out of all clinical practice and not entering cases in the case log for more than 3 weeks in consecutive, just reach out to us and just let us know that you're taking time off and why. Thanks for alerting us to that.
Yeah, that's great. Before we wrap it up, I just wanted to address a couple of questions that were in the question and answer column that came up. We're expressing maybe a little bit of frustration around or maybe getting at, is this really necessary? This seems burdensome. And is this really necessary to fulfill, the board's mission? And we certainly understand where that sentiment comes from. I mean, this is a big change and there is burden here, and we recognize that. I think the way we've looked at this as a board, and we've considered this change since prior to the pandemic. We've been talking about this change for nearly a decade now and trying to figure out how to do it in the most seamless way possible to serve our diplomates. Of course, our mission is that we have to serve the public, but we also serve our diplomates by making these processes as seamless as we can make them. We're a self-governing specialty, and with self-governance comes a great deal of responsibility. So the onus is on us. If we want to continue to self-govern, the onus is on us to develop robust processes of assessment, whereby when we confer board certification, the public can really trust that. And as soon as we appear as though we're just going through steps to check off boxes and things like this, then we start to lose the trust of the public. We also have your best interests in mind. So I hope that helps you to understand, where we're coming from. We had a couple of questions about, well, how are you going to test us on these cases? And one just kind of popped up, which reminded me about that. And, you can imagine you're going to have these 10 cases. You're going to have 5 cases for an hour and then 5 cases for an hour with 2 different examiners. So 4 examiners separated in these rooms. And they're going to ask you about your thought processes. Why did you make this decision? Oh, how did you manage this complication? What would you have done? Let's say that you did a tonsillectomy and you didn't have a post-tonsillectomy bleed. Well, we still might ask you, well, what would you have done if you had a post-tonsillectomy bleed and it was of this severity? How would you have managed that? So there are going to be cases, there are going to be questions that are directly related to the cases and also indirectly related to the cases, but still related to the cases, and so we're not going to go out on it, we're not planning to go off on tangents on this. So I hope that helps alleviate some of I think it's pretty common sense if you really think about the questions you've been asked about cases you presented to your attendings, to your colleagues in the past. You're going to get those same kinds of things here. We're not going to go off the board. That's certainly not our intent. And then we do have a scoring rubric. We do have a psychometrician who is employed by this board, who we've worked with for certainly over a decade, who's overseen every assessment, whether it's written, whether it's oral, whether it's one of our CPO or other, subspecialty assessments. So, and he works with 2 or 3 other boards doing this. So we have tremendous experience in these types of assessments. Brian, I know we're about 15 minutes past the hour. This might be a decent time to wrap this up, and we'll be town halling with all of you in the future on additional topics. And if you have additional questions, please reach out to the board and we'll answer those for you. I think, Jeff, I'll turn it over to you to wish everyone a good night.
Okay, thank you very much, Tim. We've had a lot of questions, a lot will come up, and that's why, in particular, I think, Brian, one slide you could bring back up is just reminding people that they do have a navigator working with them by alphabetical kind of constructs there, and we have a great staff who will communicate questions and answers to you where they can. And if there are areas or other challenges you're facing, certainly Dr. Newsenbaum is available to any candidate that's going through this process as well. So this is really kind of a key concept to really be engaged and involved. We encourage questions and encourage interaction. We wish you all the very best in this process. we're not, it's not a tricky process. We're not trying to catch anybody. We're trying to fulfill our mission, and we're trying to be very reasonable as we do that. So, once again, I hope this is helpful to you all. Please reach out to the board, and thank you for your attention and your attendance and your very high level of engagement with great questions tonight.
Thank you, everyone.
Good night, everyone.